So TRIMM-2 was a prospective multi-cohort trial in patients with relapsed or refractory multiple myeloma, testing the combination of daratumumab, which is anti-CD38 monoclonal antibody, with a novel bispecific antibody called Talquetamab, which is targeting to myeloma-associated antigen GPRC5D. We tested two different dose levels, 0.4 milligrams per kilograms weekly dosing and 0.8 milligrams per kilograms biweekly dosing in combination with daratumumab. Overall, we enroll patients who had 3 or more lines of prior therapies with relapsed refractory multiple myeloma, or who are double refractory to proteasome inhibitor or immunomodulatory drug. We allowed patients who had prior anti-CD38 monoclonal antibody-based therapies. The washout period was greater than 90 days. This study did allow prior CAR T-cell therapy or exposure to other bispecific monoclonal antibodies. Patient received 2 different dose levels of Talquetamab at 0.4 or 0.8 milligrams per kilograms with a standard schedule of daratumumab. Patient had an opportunity to have a less frequent dosing if they had a disease response after cycle 4 and cycle 8. And the primary objective of this trial to assess the overall safety of this combination as well as understand the efficacy of this combination. So in this meeting, we'll be presenting the data on 65 patients in total with additional 10 months of follow-up. And when you look at this heavily pretreated myeloma patient population, we saw that the overall response rate in either cohort was greater than 70%. Majority of the responses were either VGPR or CR. And we also noticed that most of the responses were quite rapid, and they appeared to deepen over time as the patients stayed on therapy for a long period of time. There were very few patients who actually had to stop treatment because of the AEs. There was one patient who died from infection-related complications, which was thought to be related to the study intervention. But overall, we did not see any additional serious safety signal compared to the Talquetamab monotherapy, which has already been published. We also noted that among the patients who had prior CAR T-cell therapy or bispecific antibody therapy, we saw quite encouraging overall response rates. It's too early to say at this point. I think both monotherapy study is still in follow-up, and we are still kind of accumulating more additional follow-up data on this patient who was treated on this trial. The whole goal of this combination is to improve upon what was achieved with a single agent Talquetamab, which is already a good drug with more than 70% overall response rate. We are hoping that this study will establish a new baseline of combining the Talquetamab with the daratumumab, and also show that Talquetamab can be safely combined with other myeloma-directed therapies, and multiple trials exploring different combinations of Talquetamab are currently underway.